Good morning. I'm Huda Akil. I'm a professor of psychiatry and the co-director of the Molecular and Behavioral Neuroscience Institute here at the University of Michigan. And I would like to welcome you to the second day of this conference on depression on college campuses. Obviously, a very important topic to all of us, to obviously the people who are depressed, but also all of us who would like to deal with it and help prevent it. I am told that to tell you that our speaker, whom I'm about to introduce, will be taking questions, and so you have one of two choices. You can either walk up to the microphone, or there will be volunteers who will be coming around, passing around note cards, and so you can write a question, give it to them, and they will pass it on to the speaker. So it gives me great pleasure to introduce our first and lead speaker of today, Dr. Pardes, Dr. Herbert Pardes. Herb. I'm used to calling him Herb, so it's hard for me to say the full name, Dr. Herbert Pardes. So Dr. Pardes is currently president and CEO of York-Presbyterian Hospital and its healthcare system. But it's really hard to encapsulate the depth and breadth of what Dr. Pardes is bringing to the table here today. As you know, in our field of academic medicine, of academia in general, there are many people who make many different kinds of contributions, but I would venture to say that there aren't even a handful of people in this country who bring to the table the variety and depth of experience that Dr. Herbert Pardes brings to us today, because he has had experience in leadership, not just in psychiatry, but in medicine in general, and not just in academia, but in government, and not just on the academic end, but on the hospital end. And so it's an absolutely remarkable vantage point that he has to talk to us. So, just to give you a brief glimpse of this experience, Dr. Pardes was the director of the National Institute of Mental Health, NIMH, and the U.S. Assistant Surgeon General during the Carter and Reagan administration. He was also the president of the American Psychiatric Association. In 1984, he became the chair of psychiatry at Columbia University, and then he became, 5 years later, the dean and the vice presidents for health sciences at Columbia University. And Herb, if I remember correctly, you kept all jobs going at the same time, which is like mind-blowing. Then in 1999, Dr. Pardes was chosen to lead the New York Presbyterian Hospital, so he went from the university to the hospital position, and during this time has greatly, dramatically enhanced the already great stature of this hospital, so that now it was voted number 6 in the U.S. News and World Report of America's Best Hospital, and it gets all kinds of awards. He has also served on numerous presidential commissions about health for multiple presidents like Bush and Clinton, and has thought deeply about the system in general. I have watched him in several venues. One of them was when he was Dean and VP of Health Affairs, and my son was starting his MD Ph.D. program at Columbia, and I heard him talk to the students on White Coat Day, the first ceremony, and I felt it was an amazingly inspiring speech that combined both the sense of humanity about what it means to be a physician, but also a vision of what medicine was going to look like in the 21st century. I've also watched him lead NARSAD, which is an organization that funds research for psychiatric problems, and I've seen him do that for many years with great skill and compassion, and at the same time a sense of purpose and mission that are incomparable. So for these and many, many other contributions to our field, Dr. Pardes has received numerous awards and recognitions that I don't have time to enumerate, but I would like to mention a couple of them. One is the election to the Institute of Medicine of the National Academy of Science, membership in the American Academy of Arts and Sciences, a very prestigious award called the Sarnat Award given by the Institute of Medicine, and the U.S. Army Commendation Medal. It's with great pleasure that I bring you Dr. Herb Pardes, who will be talking about optimizing the university's approach to depression. Herb.
Thank you very much, Huda, and thank you all for being here. I'm sure you realize, and if you don't, I'll tell you that Huda Akil is one of the most admired figures in the field of neuroscience and psychiatric research in the country, long-standing friend, and a wonderful credit not only to the University of Michigan, but to the entire country. This is a very interesting topic, and a topic which has much complexity to it and endless perspectives. And it was reminiscent somewhat of the child who walks over to his mother and says, "Mom, where do I come from?" And his mother says, "Well, there was a man named Adam. Adam met a woman named Eve. They got together, they lived in a lovely place, and they gradually created more human beings." So the son, to check it out, probably had a research instinct, you don't take one finding, went over to his father and said, "Dad, where do I come from?" And the father said, "Well, there's a certain kind of animal. That animal evolved into a kind of ape. The ape became more like a human being and gradually evolved into you, me, and all other people." So the child, confused by these contrasting perspectives, went over to his mother and said, "Mom, I don't get it. You told me we came from Adam and Eve. Dad told me we came from apes and other kinds of animals. Could you clarify?" She said, "Well, he was talking about his side of the family." I think any of us could probably, and you're doing it, spend enormous amount of time on this because there are so many aspects to it. And as I re-immersed myself, you can imagine my day job is running a hospital, so I hadn't been focusing directly on the problems of mental health problems in college. So I did some re-looking at the issues. And as I was doing it, I also thought of my own experiences over the years. And mental health, as Huda said, has been my primary discipline and my focus really for God knows how long. And I recalled, as a 28-year-old psychiatrist, I was drafted into the Army at the conclusion of my first year of residency. And I had the good fortune to go to Fort Myer in Arlington, Virginia. And the reason I went there is because they wanted to have a mental hygiene clinic set up. Now, imagine in the room we've got people who are professionals, people who are probably consumers of mental health services, maybe house staff, I don't know, but imagine being a first-year resident being told that we'd like you to set up a mental hygiene clinic at Fort Myer, and the service we were supposed to undertake was to take care of the soldiers who developed mental health problems, and that included the Pentagon. But the reason that they set up the mental hygiene clinic was kind of interesting, and that was that there was a debate. They had some space, they wanted to set up a new clinic, and the debate involved whether they should set up a podiatry clinic or a psychiatry clinic. And as they were having the debate, tragically, 2 soldiers committed suicide, and that sealed the deal. So I set up that mental hygiene clinic. And you can imagine, this is now the 1960s, that stigma was far more pervasive and intense, particularly in the Army. I mean, the Army and its attitude toward these kinds of issues is worth a discussion unto itself. Because the prevailing culture in the Army, at least at those days, I haven't been that close to them recently, was that anything associated with mental health was taboo. And to illustrate it in a kind of very nuanced way, an officer called me up and he said to me, "I want to talk to you about a man in my company." And I said, "Fine." He walked over, came into my office. He said, "I want to talk to you about this man. It's me." And in many ways, that kind of epitomized the ambivalence people had, or the reluctance people had, in too directly talking about mental health problems. 10 years later, I had taken over a position as head of psychiatry in the University Hospital at Downstate Medical Center in New York. And the president of the hospital, we had all kinds of services, a full-scale hospital, approached me for a discussion a few days after I started. And what was his concern? His concern, since we had a closed psychiatric ward, was that I make sure that no psychiatric patient escaped. And what was he concerned about? He was concerned about the possibility, which struck me as kind of interesting, people's fantasies run wild, that a psychiatric patient would escape from the ward, run around the hospital, and start taking the IVs out of all the other patients. Now, I would imagine he had no analogous discussion with any other chief of service. But mental health is a wonderful magnet for all kinds of elaborate speculations, fantasies, concerns, preoccupations, and the like. And it has always experienced special handling. And stigma manifests itself in countless ways. I had people who had reluctance to contribute to mental health causes because even though they didn't have mental illness problems in their family, somebody might think they had mental illness problems as a result of that. And you can recall a time when people thought that it was almost like a taint that ran through your family. If, God forbid, you had that, then other people would have it, and perhaps that meant things about relationships with other people and the like. The extraordinary breadth of issues that pertain to mental health has a substantial influence. And the difficulty of making the distinction between what is normality and when that normality becomes abnormality, if you will, is omnipresent. Depression, after the loss of a close relative or friend, is normal. But when does it become abnormal? Anxiety on taking a test or applying for a job is normal. But when does it become excessive? Obsessiveness, which helps people ensure that details are attended to, is adaptive. But when does it become pathological? The range and the continuum from normality to abnormality or to mental illness produce some very difficult, thorny questions. In addition, in a society in which increasingly fixing responsibility is a key issue, particularly in the event of any adverse episode. I saw on the, probably, who hasn't been seeing the primary and almost only discussion of the day is the AIG bonuses, and President Obama saying everybody in Washington is trying to figure out who they can point to as the responsible entity. But the unique situation represented by young people who come to college, transitioning from a life in which their parents were busy making a lot of the decisions, to lives in which the students increasingly realize their prerogatives and their independence, creates yet special additional features. And the changing nature of mental health in the general society reflects itself in college. Some 40 to 50 years ago, there were few medications for mental health conditions. Many people quietly and secretively went for mental health help, on the one hand. Others who appeared blatantly disturbed were put into hospitals, often for long periods of time. At its peak, the number of people in psychiatric hospitals in the United States was 556,000. You can imagine if those numbers had continued with the growth of the population, we would have several million people today in chronic hospitals. In that same era, some 3/4 of mental health services were delivered in the inpatient setting, and the assortment of treatments was limited. So there wasn't as much outpatient treatment. It wasn't as typical for people to go to one's counselor, one therapist, but there was a lot of inpatient care. Now, over the years, there developed an increasing momentum to situate mental health services in visible areas of the community. CMHCs, the Community Mental Health Centers, represented a federal program to accomplish this change. The idea was that we would put a community mental health center in areas responsible for about 200,000 people. We'd develop about 1,500 of them, and we'd map the whole country with mental health services that were visible and available, and that would help in the destigmatization as well as make services accessible. Simultaneously, there was an increasing use of psychological therapies and an accompanying increase in the repertoire of antidepressive, anti-anxiety, antipsychotic medications. When I came into the field, the only medication we had was Thorazine, some sedatives, and people used a variety of convulsive therapies. These improvements in treatment changed the nature and potential of what you could do with people who had psychiatric problems. At the same time, the society made the move to vastly increase the number of people with mental health backgrounds. And so the National Institute of Mental Health supported for years training of social workers, nurses, psychiatrists, psychologists, not paraprofessionals, all kinds of people doing mental health. And very important were epidemiological studies of the extraordinary amount of illness and disability for which mental health is responsible. You know, just a funny comment. I was in China once talking about mental health in the United States, and I had a translator, and the figures that had come out were that about 19% of the people in the United States at any one point had a psychiatric problem, and the translator made a little mistake, and he translated it 95%. And the Chinese just broke up in laughter. They were about a serious group, and it was as if the facts finally came out. The United States was composed of a complete bunch of people with mental health problems. Now, beyond the importance of the mental illness itself is the increasing recognition of its linkage to other illnesses. If you have a heart attack, one of the most important prognostic factors, and it's a negative prognostic factor, is the coexistence of a depression. And people in this room can speak far better than I can about the linkages between psychiatric problems and all kinds of non-psychiatric medical illnesses. I say this all as a context. I guess John Greedon, when he called me, was not looking for somebody who was in the trenches working in this field, but somebody who might give a broad overview. And just to say, I have in the past had a full psychiatric practice, so all kinds of patients in an outpatient setting, and have directed hospital outpatient programs. I guess I've really been through many different areas of mental health over the years, and then served for about 6 years as NIMH director, in which we worked on mental health policy, and these issues were issues we were trying to think of from a national perspective. From time to time, I'm asked if I still practice psychiatry. When I was dean or a hospital president, and I point out that I have no designated patients, but I still practice, and I'm an expert in narcissism. As you focus down on the pervasive issues in colleges regarding mental health, mental illness, and the like, you find the following. First, there are many reports of increased mental health problems on campus and also of an increase in severity. Now, these findings don't enjoy universal agreement. There are some people who think differently, and there are some who would suggest if you do these studies very carefully in an actuarial way, that some of the supposed increases either diminish or disappear. But the predominant views, as I did the reading, was that there had been an increase. Certainly more people are coming for counseling services. And on the other hand, as you and I and all of us know, many people who have mental health problems do not come. There has clearly been a decrease in stigma, which allows the discussion of mental health. One of the things we used to yearn for when we talked about how would you destigmatize was if somebody put a regular serial on TV, which everybody liked and looked and saw, a lot of people who watched it, and there was somebody who had mental health problems who was well treated and it was there, or dealt with the issue, and more, what's happened in the atmosphere and the general environment has infected what's happened in media, and so people talk, and it's a much more open thing. But that doesn't mean it doesn't exist. The societal use of psychoactive medications, which I mentioned, has had its parallel in people in colleges. Many students come to college already having some kind of mental health treatment, psychotherapy, medications. In fact, John sent me a communication which said some 10 to 15% of the student body arriving on campus during freshman year were already on psychoactive medications. The position of most mental health professionals is that the use of medications is a valuable adjunct in attending to a number of psychiatric or mental health problems. And that position was not necessarily the position held in the 60s or 70s when many people who focused on primarily psychological therapies had skepticism as whether medications were a help or a hindrance. In colleges, the request for vocational or career counseling seems to have declined. Whether this is related to the increase in students coming for mental health counseling is an interesting question. A derivative question is whether those services should be housed together or not. In some places they are, in some places they're not. And there are many pluses and minuses on each side. The overlap between career counseling and mental health counseling was illustrated by one study which showed that approximately 11% of students who came in for career counseling also received treatment for mental health issues as part of that counseling experience. At the same time, of the students who entered counseling for mental health issues, approximately 20% also sought career counseling. Those numbers are obviously approximations. And one of the things you're dealing with in mental health, you're always dealing with the question of how much is reported and how much is not. I mean, we talk about 30,000 suicides in the country in a year, but how many suicides happened which were never designated as suicides is open to question. In any event, it illustrates the closeness between mental health counseling and career counseling. As in the general society, mental health problems inevitably involve issues of confidentiality. And actually, privacy is a concern that goes well beyond mental health problems. In the developing efforts to make the healthcare system more electronic, there's been a lot of focus on HIT, and one of the things I applaud in the stimulus package is the fact that we're finally seeing money put in there to back up the development of an interconnected EMR system or electronic medical record system for the country. But the privacy advocates are very intent upon protecting appropriately people's prerogatives regarding their own health information. At the same time, there are many parents who still see their college student son or daughter as their responsibility. And how one handles the relationship to the parents can be a knotty issue. My understanding is that a suicide at MIT led to a legal situation in which the family complained about inadequate information from the university. Let me tell you a story that took place in the hospital which illustrates the complexity. A family brought in a teenager because the teenager was having some problems. The teenager, in speaking to one of our clinicians, told the clinician that she intended to commit suicide but didn't want to tell her parents. So the counselor, clinician, was caught with the inability to tell that to the parents, but the need to act on it. So she told the parents we were going to hospitalize the patient. And the parents became furious. They didn't understand why we were hospitalizing the patient. So these issues of confidentiality, particularly in the mental health field, are important ones. In the extraordinary rich and diverse culture that American society has become, there are also countless populations with unique characteristics. This diversity has had a substantial impact on mental health services, on their use, their accessibility. As examples, it's generally found that students coming from more challenged socioeconomic backgrounds may be more reluctant to come for services. Further, some minority groups and groups of international students may approach counseling services less frequently or with greater reluctance. The question of family background, religious orientation, both have an impact on how a student will perceive the value or attractiveness of mental health services. Obviously, whether the students have previously used mental health services, whether they've had mental health problems before, will impact what happens in their handling of the same issues in college. Those who've gone for counseling before seem a bit more ready to go later. All of this has been given new significance with the generalized increase in societal pressure and stress secondary to developing national and worldwide issues in the last couple of years. The fact that we've become a global enterprise has profound impact. The perceived position of the United States, which has for years been the world leader, and for the most part an admired leader, has been challenged by virtue of a host of international stresses and controversial U.S. policies. And this has been compounded further by the current economic tsunami, which has had an extraordinary impact on almost everything: people's jobs, health insurance, their ability to provide basic needs for their family, our educational institutions, the economic resources to support college careers, and on and on. You can't overstate the impact of the extraordinary period in which we are living right now. I would say that the election of a widely acclaimed choice for president, who's elicited an extraordinary enthusiasm, particularly from the younger population, has been a positive in this rather difficult environment. And it appears, interestingly enough, that the degree of interest in government and public service is going up as President Obama engenders a greater readiness among large parts of the population to be involved in promoting national priorities. And yet a squeeze on finances can mean a squeeze on university finances, which means a squeeze on available resources to support all kinds of things, including mental health services. Obviously, given the previous perceived increase in numbers of students coming for help and the potentially increased severity, one would think the resources for mental health and services in universities may need to be at the least maintained, if not increased. How does the student approach these issues? In one student that asked students where they go for help, the preferred sources of help in priority listing were, number one, myself. Number two, a close friend. Number three, a close relative. Number four, the clergy. And only in fifth place did we get to a mental health counselor. It would appear that women are more comfortable coming for services and do come in greater number than men. The notion of women as being more comfortable in interactive, intercommunicative, and interpersonal skills is a phenomenon that has been recognized widely. I have a very wonderful couple friends of ours who are very well known in the art field, very prominent. You'd know their names in a minute. And from time to time, we have dinner with them. And we have a recurrent discussion as to whether she can convince him to go to get a general doctor to check him out. Whether people perceive themselves as having a mental health problem is relevant. There are many who will simply ignore or shrug off the problem. There are others who may identify personal mental health problems with accuracy. And there are still others who may overstate either the frequency or the degree of mental health problems with which they are confronted. One report found that depression or anxiety was prevalent in about 15.6% of the population. It is suggested, too, that the college population, compared to control populations of people of analogous age, not in college, show a somewhat lower frequency of mental health problems. One's attitude about the likely benefit from counseling services or mental health therapy is obviously pertinent to the readiness of someone to go or not go, and also contributes a good deal to the likely success or failure of the treatment. People who come in with regard to treatments in general with a somewhat more optimistic or hopeful attitude usually do better in treatments. The awareness of the availability of counseling or mental health services and or the insurance, if you need to have it financially covered for mental health services, is important in determining whether someone does or does not seek help. The likely ability of individuals to secure help and support from friends and families can work two ways. In one scenario, they may, as a result of such help and support, be less inclined to go for professional counseling. And yet, on the other hand, they may be encouraged by people close to them to go for professional help. When one asks the question, why people come, then you get answers which tend to aggregate with some variation. For example, in one study, the main reasons were found to be suicidal thinking, panic, anxiety, concerns, and depression. Other problems cited included relationship problems, family issues, sexuality, and finances. Despite the studies which suggest that college populations may have less in the way of mental health problems, it is attention-grabbing to see reports like one recently issued in USA Today, which said that some 50% of college students felt suicidal and 7% said they had attempted it. Even though those figures are lower in college than the rest of the society, they're certainly arresting. In this increasingly complicated and most sensitive set of issues, what's the stance and attitude of institutions? It will not surprise you that this also varies. Institutions are affected by their cultural context. There are some institutions in areas where the importance of religion is far greater. There, the preference for many with mental health issues would be for turning to religious expertise to deal with mental health problems, seeking religious consultation and help rather than help from a designated mental health professional. Nowadays, the vast majority of people in religion have both experience and some training in the psychological and mental health area, since so much of what they do involves such issues. Different groups around the country have tried to attack this problem in varied ways. Reflecting broadly on the problem, then, a number of things come to mind. First, there are students who will go through their college career, need some advice and help, and may come for limited counseling, get the help, and go on. Many of them have been benefited by that interaction. Others may come, decide it's not that helpful and necessary, and deal with their issues with other resources. There are also individuals with serious mental health problems, not exclusively related to the college experience, but perhaps exacerbated by the stress of college, whose history in life will necessitate dealing with that psychiatric problem. Securing quality treatment, which may be time-limited or ongoing, may be critical in helping them overcome or deal with that problem and be able to conduct the rest of their life. Talk of suicide attempts, and even more of instances of completed suicide, creates enormous distress throughout. It has profound effect on the many people in the circle around the identified person. I can tell you as a psychotherapist that dealing with a suicidal patient is always concerning to a mental health professional, as well as to family and friends. Finding ways to help the individual overcome the feelings that suggest suicide as an appropriate action is a most formidable challenge. And still, for experienced mental health professionals, that's what they do, and it's not uncommon in their practice, and for the most part, many do it extremely well. On the other hand, the detection of intention to make a suicide attempt is not easy. There are important facts to know. Relevant is a history of previous suicidal ideation or certainly of suicide attempts. If you talk about violence almost of any sort, probably the best predictor is previous episodes of violence. Also relevant is a history of suicide in the family. Another factor for consideration is a tendency to use drug and alcohol in the person who has suicidal tendencies. And impulsivity is also important. In addition to these kinds of valuable data points, however, good clinical judgment, the skill of the mental health professional in making a reasonable determination, may be critical in determining the outcome. For the college and the university, detection and prevention of a potential suicide is absolutely central. No one wants to see someone make a suicide attempt and certainly not complete a suicide. Beyond its tragedy for the individual, such tragic events have a most profound effect on other students, professors, and family. It's terrifying to the entire university community. And people strive for ways to bring this under control and maximize prevention. The University of Illinois, in an interesting study, has mandated a minimum of 4 counseling sessions for anyone who expresses suicidal ideation. They reported that as a result of their efforts, they cut their suicidal frequency in half. This leads us to the general question of the services made available to students in relationship to mental health issues. Certainly, there should be every effort made to have adequate mental health resources. There are estimates given as to what number of full-time mental health counselors might be a reasonable number for a given number of students. One authority suggested it be about 1 counselor per 1,500 FTE students. My understanding is that estimate does not match the number of counselors available in most universities today. In other words, we are under-personed for that. The mental health services should be accessible, widely known. They should include cultural diversity amongst the providers to be more congenial to students of culturally different backgrounds. It's recommended by some that services need to be dispersed to different settings within the university, and an effort made to make them as much a part of the fabric of the institution as possible. In preparing for this discussion, I spent some time with the Columbia University head of student mental health services, Dr. Richard Eichler. Just as a matter of interest, he said that they have some 33 clinicians who are available for such treatment, and that his perception, as I mentioned before, is stigma may be diminished, but it's not gone. Dr. Eichler focuses heavily on first responders, getting to people who are concerned, talking to them, encouraging them to serve as gatekeepers to care, and providing them with basic skills in recognizing and approaching students in distress. He places great emphasis on having counselors out and about, not in formal settings, but in a more fluid, more interactive way. He cites the work of experts in this field of school violence, who argue that the best sources of information about potentially dangerous students are other students and perhaps teachers. The challenge is to create an atmosphere of trust in which those who are aware of troubling, potentially dangerous situations have faith that the institution will use what information they might wish to share in a reasoned and good faith manner. And that obviously then speaks to the question of university leadership and faculty leadership in creating that kind of trusting climate. The diversity of issues with which the counselors deal cannot be overstated. This calls for good interpersonal skills, knowledge, and sensitivity to what's transpiring in the environment, and to many different perspectives, as well as awareness of the range of personal situations. I mean, to counsel well, I believe people have to have an understanding, a reasonableness, a broad acceptance, because people are very different, people have very different perspectives, and the main point is to be trying to help the people who come in. Dr. Eichler was also very attentive to certain myths, counterproductive myths. For example, one myth involves the notion that if you ask people about suicide, you might precipitate a suicide. In fact, he says, asking might do the opposite and allow a critical conversation which otherwise might not have happened. He pointed out that often many faculty have their own pressures, and they certainly do in terms of their careers, their labs, their educational responsibilities, promotion, tenure. They may be uneasy about getting involved in messy situations. They may tend to avoid them. And yet people are different, there are some with little training or background who may immerse themselves in highly complicated issues and get in over their head. Columbia has satellite offices in 5 different locations, including residence halls, the law school. They're open late in the evening when students are in their dorms. No appointments needed. They see many people in each setting. The idea behind these offices is to offer students multiple points of access to care, including informal settings where stigma might be reduced. The emphasis on rapid access is great at Columbia. They want students to be able to connect with a provider within 24 hours, and they carefully distinguish individuals with different levels of seriousness with regard to their mental health status. He provided me with self-report data from the NCHA, which showed that among students proclaiming problems, the following data. First, 14.9% were diagnosed with depression at some point in their life. And over the last 12 months, 76.4% reported a feeling of sadness, 43.1% felt so depressed it was difficult to function. Of those diagnosed, the ones in therapy for depression constituted some 24.2%. Of those diagnosed, 35.8% were taking medications for depression. Some 10.3% had seriously considered suicide. 1.8% had attempted suicide. 1.8% had anorexia, and 2% reported they had bulimia. 13.1% had anxiety disorder, and 2.6% had substance abuse problems. A recent study of self-injury behavior suggested that 17% of students at 2 Ivy schools reported having practiced some kind of self-injury behavior at some point in their lives, and the prevalence rate over 12 months was some 7.3%. A Big Ten study that you, I'm sure, are familiar with, suggested that the suicide rate on college campuses was about, the way I have it here is at 7.5% per 100,000, or about half the rate of the same age cohort not enrolled in college. That report added that they felt that the services in mental health and other supports on college campuses hopefully might be being protective against suicide. Also, the fact that young people attending college theoretically have a brighter future and more resources of all sorts is enormously helpful. Institutions, both who have had and those who have not had widely publicized instances involving suicidal behavior, have tried all kinds of things to deal with them. They've had to deal with the various legal and personal issues in which they were involved. And I can tell you, it's almost, I was mentioning to somebody yesterday that it'd be interesting to have a symposium in which administrations of large institutions discuss the handling of these kind of very difficult problems in the public arena with the media, PR, and legal issues involved. At Columbia, they arrange a wide range of dinner discussions to help create a climate of openness. To give you a flavor of those discussions, some of the topics were: first, international student adjustment. Second, in quotes, but I don't want to be a doctor or a lawyer. Third, coming out at Columbia. Fourth, managing stress. Fifth, long-distance relationships. Sixth, returning home for the holidays. 7, balancing work and family. 8, working with a difficult student. 9, getting the dissertation done. And I might add that many would argue that whatever the nature of problems for the undergraduate student, the problems are equal, if not even greater, for the graduate students. Other institutions have pioneered systems which very quickly and easily set up available appointments, often through telephone. The triage challenge for institutions with large numbers is whether to refer to community resources or not. There are, of course, in universities such as Michigan, Columbia, and the like, medical centers and psychiatric services, so those additional resources are available. At Columbia, they've done a great deal in generating criteria to establish the extent of the acuity. How immediate, how imminent is the situation? And the general advice, of course, is to err on the side of caution. I offer the Columbia program as just one example. Their system, which involves categorizing the nature of the emergency, providing tailored responsiveness, they refer to as a rapid access system. And it is apparently widely appreciated by the student body. Interestingly enough, when they look from the years 1993/4 to 2005/6, the number of students seeking treatment has spiked dramatically. So where do you come out on this enormously important and complex issue? First, I'm impressed by the serious and broad-based nature of these issues. I can tell you that in the hospital, we have analogous issues. And for what it's worth, I'll just mention an example of what light brings you. I ran the psychiatric department, as Huda said, for a number of years at Columbia. And I remember being out for my birthday with my kids and my significant other. And I got a call from the psychiatrist who was direct in charge of clinical services. And the call went like this: Herb, I'm not sure if it's one of our patients, but somebody just left an emergency room, went on a Staten Island ferry, and killed 2 people and stabbed 7 others. Usually when a call comes in which starts, we're not sure it's ours. It's ours. And you can imagine, and I'm happy to talk to it, the array of complex issues with which you got immersed. To give you something a little more recent, just to tell you that people who work in the management of these institutions are constantly confronted by issues related to various kinds of violence, self-injury, and the like. We also were the setting in which Flexo Burris decided to shoot himself in the leg in a club somewhere. And we had the set of issues that surround that. And New York loves good media stories. So that was a tremendous amount of activity and involvement. May have had some impact on the Giants' good fortunes in the Super Bowl. But again, what often happens, and is perhaps not attended to as much, is that the universities, whether it's dealing with suicide, violence, and the like, hospitals, medical schools, get heavily involved, and these are formidable challenges to exactly how to handle them. And universities today have much in the way of challenge anyway. And this is doubly true in this time of extraordinary economic stress. But whether at a good time or a bad time, to me it's apparent that mental health and mental health problems and attention to the mental health issues of students and graduate students have to be a top priority. Setting a tone of recognition of these problems by the leadership in the university is critical. It includes the equivalent and even handling of mental health problems to the handling of any other medical problem. Adequate resources and counseling service and staff with easy accessibility who are widely visible to ensure knowledge of their availability. These are all important steps. And also in this era when President Obama calls for all of us to assert a responsibility beyond ourselves, the awareness of our colleagues and friends and relatives and sensitivity to their problems is important. A readiness to identify a problem when one is a parent, to try to provide support, and if appropriate, encourage the person to seek professional help is an important function for everyone. I believe discussions of how one does that, what signs to look for, can be most valuable. I believe, too, that the appearance of the mental health counselors as inviting, attentive, sensitive, friendly are characteristics for which we should strive. Do you feel that you would want to talk to that person? Do you get the sense that that person would be trusting? Do you feel that person would care? I can tell you at the hospital, we are focused as the highest priority on creating patient-based services which are attentive and caring to the patient. You know, over the years, people have treated mental health problems with various approaches to keep them away from us. First, we thought of them as other beings, possessed with spirits in their head. And you may or may not recall that centuries ago, they actually used what they call trephining to let the bad spirits out of the skull. At one point, mentally ill people were chained in prisons because they were presumed violent. And the data on this is that mental health people are actually very infrequently violent. They're usually scared of other people, not necessarily looking to be aggressive toward them. In later years, this was followed by placing such patients in chronic hospitals, usually at a distance from major population centers. But we have changed as a society. Mental health has increasingly gained recognition and acceptance as part of the life of the whole society. The development of community mental health centers, a focus on destigmatization, better treatments, evidence of people who can actually get well and get better through mental health problems, all have been important. There's much more research on mental health in Michigan, and Huda and John and Stan Watson and others represent some of the leading mental health researchers in the country. The NIMH Institute has become a very substantial and big institute focusing on that, along with other entities, tries to help in terms of support for research in mental health areas. Diverse parts of our society have encouraged a broader approach to the problems of mental health. Many colleges and universities have been leaders in this effort, and that takes people with enlightened perspective and forward thinking. I have personally had the good fortune in my practice went on for about a decade or so, to have escaped the tragedy of any patient that I was directly taking care of committing suicide. But the suicidal ideation was very frequent. I have, however, been in settings where these episodes became very close to my own functioning. In one, it was a colleague psychiatrist who committed the suicide. In another, a medical student being taken care of by a resident on one of the university hospital wards committed suicide. And you can imagine the tragedy. I can tell you directly, when I was at Downstate Medical Center and got a call from the dean's office. Downstate Medical Center is a big building about 12, 15 stories high, to come and identify a body that was lying right next to the dean's office window. And there was the patient who was on the ward who had been treated by the residents. These are tragic events. They're as tragic as a person dying from cancer or heart disease or stroke. The good news is that we can do better, and we are doing better. I'm most impressed by the attentiveness of the University of Michigan to these issues. University of Michigan is one of the outstanding academic centers of the world, and has produced so much in so many areas. Doesn't surprise me that a leader like John Greedon, who's the most thoughtful and creative psychiatric researcher and clinician, would play such a role in creating this enormous attention as it deserves to the issue of depression. I thank you for the opportunity to talk with you. There's so much and the discussion is so rich that we could easily extend this symposium over months rather than 2 days. But I do hope my thoughts will be of some help in the handling and discussion of these issues. The University of Michigan represents the proudest tradition of great universities in this country. It is extremely attractive to me to see it lead the way in an area of such extraordinary importance. Thank you. Please.
Dr. Pardes, Henry Chung from NYU. I really wanted to start with the recent AIG issue and Senator Grassley making his comment, which links to your comment about stigma, where he encouraged AIG executives to either resign or kill themselves, really connoting the Japanese approach towards contrition, particularly in the public domain. It's moving from that comment to really the issue of psychiatric diagnosis. It's really interesting to me that the Asian countries, speaking of international students, have among the highest suicide rates in the world. And yet, epidemiologically, they actually have fairly low rates of DSM-4 depression, as far as we know from the studies. So how do you make sense of this? And of course, I'm also interested in your comment about Senator Grassley's thoughts, which I think has done tremendous harm to the entire nation and possibly the world as it relates to thoughts of contrition to either resign or kill themselves.
Well, I think that Senator Grassley himself had some comments to make subsequent to that comment and probably felt a little uneasy about the fact that he had maybe taken a step and gone a little too far. The anger of the country is overwhelming and palpable. I find in dealing with some of the issues related to this financial disaster that the notion that anybody, whether it was the direct salesman or somebody who is directing the sales of these mortgages, in which they knowingly induced somebody to take on a mortgage which would jump in terms of cost, that person would never be able to handle, unconscionable. I think that is really disgraceful. And so I share the rage that many have on some aspects of these issues. However, I think that we've got to be careful that the populist fury that's been unleashed in the country in the last, I'd say, 9 months or so, can have all kinds of dangerous effects. It can intimidate some of the entrepreneurial or aggressive instincts for people to accomplish and be productive. So there have been people who've done some really horrendous things. Now, would I tell Mr. Madoff to kill himself? I wouldn't tell anybody to kill himself. That isn't to say that I or anybody in this room might not find some human behavior that's so egregious that you'd be tempted to act violently toward the individual. I commend to you a play, I don't know if it'll come through here, that's playing right now in New York called Ruined. And it is an extraordinary depiction of the abuse of women in Africa and the violence between contending forces there. And you've read about it in Christoph's columns. But I think where we should start off with is the fact that violence is not the way to answer bad behavior. There should be appropriate disciplinary actions. So if people who made inappropriate decisions in AIG should be disciplined, let them be disciplined. Let them tax them and insist that the money come back. Let them fine. But to suggest anybody do violence to anybody else, I find you can understand why people may be tempted, but I think that starts to remove us from a position of human principle. You don't try to hurt other people. You can insist that they be disciplined. Punishment is not inappropriate, but not the suggestion of violence. Now, you said, why might there be a disparity between the frequency of depression, DSM diagnosed depression in the Japanese culture, and yet a frequency of suicide? I think a lot of this has to do with what culture does leadership create. And I think President Obama is one of the most extraordinary individuals I've ever seen. He has a brightness and a breadth that's really breathtaking. And I'm hoping that he will recognize the anger of people about some of the inequities in our economic system, but also moderate so that that doesn't become, in turn, destructive. And I think he can set an enormously important tone here. And I think the President of the United States and leadership have a role in helping set the tone, the culture, the perspective, the principles for the country. I'll give you one small example, completely unrelated to this. I was very concerned about, as many of us are, the shortage of nurses in the country and the shortage of numbers of people who have come forward on nursing. My own feeling is that our previous president, who was here for 8 years, in the middle of that, could have gotten up and spoken to that, praised nursing as a career. Well, who did it? Johnson & Johnson. Johnson & Johnson, now I have no relationship to Johnson & Johnson. I have no relationship with any of these drug companies. But I have to say that they did a good job. They went out there, and whether that was the only reason, all of a sudden, we have more nurses. We have more people coming for what I think is one of the greatest professions in the country. And the problem really is not applicants, it's having enough nursing teaching positions and places where students can go, because there have been a lot of applicants who weren't able to find places where they could train. In any event, I assume Huda's presence on my left was not to tell me that dinner is ready, but that I should turn the stage over to the next speaker. I thank you for your attention and interest. I hope the rest of the conference is terrific.
I am actually here to thank Dr. Herb Pardes for a very stimulating talk, and I started to come up when the tone turned towards hope, which I think is something that I hope we can keep in mind during the discussion today, that as we are talking about depression and how to cure it, we hope not just to go towards the neutral, but towards the positive. And I think the Obama example is a good place to keep in mind. He wrote about the audacity of hope. So, thank you.
We're going to take about a 5-minute break, and then our panel discussion will begin. Stay seated.
It is to get food and coffee in 5 minutes. Please come on in and have a seat again. Today we are going to have a panel. While we're sitting here all in a line, it's going to be more like a meet the press, and we do hope that you will ask questions. Our goal here today is to explore a variety of issues. We're going to look at what is the university's obligation regarding provision of mental health services for students, and how does that work with the academic values of the university. We're going to ask our panelists to talk about how they recommend strategies for requesting, prioritizing, identifying, allocating resources. We're going to talk also about what can be done to bring about change in this area before a crisis occurs. We're going to talk about obstacles that each of our panelists have encountered in working towards these goals and how they have overcome them. How can we sustain positive change over the years, in particular in this current economic climate? Now, we'll be asking questions both at the microphones, and if you wish to pass up cards, we'll be collecting those. We have 3 panelists, and I'm going to introduce all of them in order, and I will then ask Provost Lewis from Emory to begin with a slide set. Provost Lewis actually was one of the founders of this conference, along with Dr. Graydon. He was at that time the Dean of Rackham, which is this building, and the Dean of the Graduate Schools at the university. And it was he and John who conceived of working on these topics together. He's now the Provost and Executive Vice President and the Asa Griggs Candler Professor of History at Emory University, and has a special interest in the history of African American studies. And before joining Emory, he was the Dean of the Horace Rackham School of Graduate Studies here at the University of Michigan, and was the Elsa Barkley Brown and Robin Kelly Collegiate Professor of History and African American Studies. He has also been on the faculty at California, Berkeley, and has written 7 books, the most recent of which were The African American Urban Experience, Perspectives from the Colonial Period to the Present, and Defending Diversity, Affirmative Action at the University of Michigan, which is a very interesting saga about what we all here at the University of Michigan went through during the past years. He was also the recipient of the Harold Johnson Diversity Award at the University of Michigan, and has been named a Fellow of the American Academy of Arts and Sciences. Our second speaker is Dr. Alan Siegel, who's the Chief of Mental Health at MIT, Mental Health Services, providing mental health service, office-based and outreach to the entire MIT campus. Prior to joining MIT in 2002, Dr. Siegel served in a number of leadership positions at the Cambridge Health Alliance, Harvard Medical School for more than 20 years, including the clinical director of the Department of Psychiatry and the director of psychology. He's been a teacher and clinical supervisor for 35 years, and he's assistant clinical professor of psychology at the Department of Psychiatry at Harvard Medical School. And his areas of interest include the development of mental health systems serving complex communities. Our third panelist is Dr. Henry Chung, who has been here before at our conference. He's the executive director for the Student Health Center and associate vice president for student health at New York University. And he's also clinical associate professor of psychiatry at New York University School of Medicine. He recently completed groundbreaking work in the Regional College Health Initiative for Collaborative Care of Depression, a college breakthrough series in which mental health professionals are integrated with primary care. This was funded through the Ed.D Foundation and the New York Community Trust. In June of last year, he also expanded his work nationally with the support of Charles T. Engelhardt Foundation by creating the National College Depression Partnership, supporting student learning by overcoming depression, which is now involving over 20 colleges and universities in the United States. Since 2003, he's also been the co-principal investigator of the National Depression Leadership Initiative, which is jointly sponsored by the American Psychiatric Association, American Academy of Family Physicians, American College of Physicians. So with those introductions, I would invite Provost Lewis to come to the podium and discuss the introductory set of slides, and then we will try and have an animated discussion about these topics amongst us, ourselves, and the audience. Thank you.
Good morning, everyone. Going to sort of move quickly into this because I realize this is a great time to move now to a Q&A, and so I and my co-panelists want to invite you into the conversation, but thought it would help by really thinking about some of the points that Herb made and reflecting on the role that the universities really can play in trying to mobilize the resources. And so let me start with the idea that clearly one of the great challenges is not to wait for a crisis to begin to actually figure out how you want to identify the resources that are needed and how to put them together. I mean, we have in recent memory Virginia Tech in Northern Illinois, but you don't have to go back that far to think of Wayne State, of Case Western, and a whole range of other examples. And so every year, certainly we have found ourselves having to deal with students who have found themselves in some form of crisis, and that crisis oftentimes extends beyond them. So one of the things I think is very, very important to know is to understand the context in which you work. I mean, one of the things that universities have to do is to spend a little more time being reflective earlier on and begin to design and really sort of create a plan. You know, it's something about not only the incidence of depression and other examples of mental illness in the general population, but who's your own population? And the degree to which you actually are introducing new policies and practices that may change some aspects of your community. Let me give an example. So 5 years ago at Emory, we decided as part of our overall strategic plan to increase the number of international students in the freshman class from 5% of all freshmen to 11 to 12% of all freshmen. We were successful, 11%. Of that 11%, 67% came from South Korea 1 year. And all of a sudden we realized then, as Bob and I remember here, that presents its own set of challenges, because then you have a whole range of cross-cultural issues that you have to think about as you look at and expect that population to actually have some of the same characteristics as your other student populations. If you extend this beyond, so one example, one plan, one idea in one part of the university has a ripple effect throughout the institution. And so trying to think of how and in what ways you match then your resources, financial, human, and medical, and other resources to actually come together to meet the needs that you have as an overall community is critical. Here goes to the point about leadership. I think there is no substitute on any campus well in advance of a crisis for senior leadership to own it. At Emory, one of the first things that Jim Wagner did in 2005, 2006 was actually to appoint a mental health task force. And so this task force came up in the context of the university's strategic planning exercise. And so you link then the overall strategic planning for the institution to some critical areas. And so I have there is the HT site. It is on the web, and so if you want to go. But that task force included not only the mental health professionals on campus, Mark McLeod, who has counseling, Mike Huey, who has student health, but a number of others who are sort of located inside of the university system to help frame an overall conversation. I think this is very, very critical. And then you have to actually, once you have that task force, then look at what are the deliverables and figure out how you sort of work through those deliverables within perhaps now a more reduced or shrunken financial envelope. But you have to figure out how you're going to prioritize and how you're going to move forward. And I'm happy to come back. I won't delineate all of the points that are there on the screen, but I would address one. I mean, I think the role of stigma still is high enough and significant enough on most of our college campuses that we should not lose sight of what it means then to both have this task force, make it visible to the community, underscore its importance, and then come back and make sure that we revisit those things that we said we're going to try to attempt to do. And then it gets down to the fundamentals of how do you pay for it, finding the resources. As provost, I spend most of my days now with trying to figure out if there's a yes in what I know is a no. And you look at it, in most of our universities, we realize now that the world in 2009 is quite unlike the world even in 2005 when we started this exercise. But there are ways of dealing with it. I mean, one of the things that we thought about, we knew we needed to hire more counselors for the counseling center. We knew we needed to provide resources. So one of the questions we put on the table, do we shift funding from other student-supported programs to accomplish that? After some conversation, the answer was no. Do you fold, then do you increase tuition and do it in such a way as to bury the additional cost in a fee hike or a tuition? And the answer there, we decided, was no. With actually great support from our students and encouragement, we actually created something called a special mental health fee and put it on the table. And so every semester, every student now pays $50 for a mental health fee, and it's actually identified as a mental health fee. And to our surprise, the students didn't revolt. In fact, they actually applauded. They realized that there was no way to actually get this issue there without, in some ways, paying for it. And the fact that it's pulled out, so they now know the mental health fee won't be used for athletics. It won't be used for something else. It will be dedicated for that purpose, and we can do it. And so if you think of that $50 per student per semester, and all of a sudden you begin to identify a base of resources and that allow you to begin to tackle some of the questions that go back to the planning exercise, that goes back to the university priorities that are reflected in leadership. And what that highlights in one way is that leadership is not only the sole responsibility then of the administration or the faculty, but that students play a critical role here in trying to frame then how we think about the delivery of services, particularly around mental health, in advance of any kind of crisis situation. So in this case, I actually would applaud our students. It was the student government sitting at the table that said this was the right thing to do and that we should encourage it, and more than that, we should advertise it in a way. And so, and you can see what that means in those subsequent bullets. It also means that we have to, and then overcoming the inertia means that we have to move from not only then providing the resources, creating a context, using then an overall framework for moving forward, but we also realize this is part of an educational community. And so what we have to do is also continue to educate. Each semester, each year, we have a new cohort of students coming in. Each year, we have a new cohort of faculty coming in. Each year, we have staff who are new to the university, but who are critical players in the delivery of all of the services and all. And so one of our great challenges is trying to figure out how we continue to educate. And so here, another way of doing it that we have actually partnered with the Counseling Center and produced, Mark McLeod actually produced a small short video, 3 to 5 minute video, inviting faculty and students into conversation, outlining what are the risk factors, figuring out who do you call, understanding how you make that available, why you should, why everyone in the community should be part of the overall network here. And what we've done is actually mounted the video on the Provost website. And so at least for faculty is there, and faculty can see it continuously. We will introduce it, have introduced it for new orientation for faculty. But that kind of visibility means then is not something that's secondary or tertiary to the overall enterprise of the institution, but it is viewed as then primary. But it's that partnership then between, in this case, the Counseling Center and academic affairs that leads out and across the institution that ensures, as we think about how you move beyond crisis, that you actually are being proactive in a certain kind of way and realizing that the best thing an educational institution can do is educate. One of the things, and it was a lesson I learned here at Michigan, and Bob and I will recall those set of meetings, is that also part of being able to pull out certain kinds of resources is important, because in a resource-rich environment, sometimes, and I remember that gnarly sort of map we had at one point was here of all the resources at Michigan for students who were seeking mental health and other kind of services, but there was no clear path. So you can end up in one place and you end up down a blind alley and it wouldn't connect to the next place. And so what we also have come, and I've learned from that experience and at Emory as well, is that one of the challenges, once we have made the resources available, we also have to make the pathways clear and available to students so that they don't actually end up being locked into a place that they don't need and aren't getting the kind of help that's sufficient. And that means then that we have to come back and really, really look at the architecture of support that we have in the institution, and we have to revisit it often, because every time we think we have it clear, those on the other side who are making use of our resources may not understand it in the ways that we imagine it. And I guess part of and then sustaining the change means then that for universities that it's not a done deal. It's not a president's task force that then issues a report with a series of deliverables and you think the job is done. And that you actually set yourselves a preliminary goal of 3 to 5 years for the introduction and the implementation of the recommendations, and then you revisit it. You revisit it not only for measuring and making sure you're meeting and the timetable you've outlined, but you connect it to a whole range of other things. So if at a university, if you have both a strategic plan and a master plan, that your mental health sort of task force should be connected. So if you're building new facilities, and then the master plan, the physical sort of sites should actually have that included. If you're looking at and trying to complete staffing plans, that you have it. But you also have an annual and periodic review of where you are, with an idea that you're going to revisit the overall plan within some kind of specified time frame. This is how you sustain it, because otherwise to introduce it without a measure of trying to figure out how you sustain it means then that you've created something once and you perhaps have not created it. You've sort of put it in place, but it's not what you want it to be. So these are sort of some initial comments as we sort of start here to begin to sort of set up a framework for more general conversation among the rest of us. Thank you.
Good morning, everybody. Thanks so much to the Planning Committee for inviting me. I don't get out of Boston very much, so I'm always glad to be seeing new sights, and this has been a very interesting couple of days. I wanted to begin my comments by mentioning that in my work in developing mental health systems in the Northeast, it's clear that no two geographic areas are the same, and the systems can't be the same. And in the same way, no two colleges and universities are the same. And so mental health systems have evolved, mental health services have evolved in the context of the university that it lives in. And that's a necessity and, in a certain way, an important element in the in my remarks. I included some slides having to do with our progress in 2005-ish from the mental health task force that MIT completed in 2001, and you can read that. I won't go over that again unless it comes up in the questions. But I wanted to tell you a little bit about MIT so you understand the context in which I work. It's a science and technical school. What that means is that you can major in writing, you can major in philosophy, you can major in linguistics, you can major in visual arts, but all the students know how to do calculus. All of the students know how to do physics and chemistry. The only people that don't are me and my staff and everyone else who works with these students who never knew it or have long forgotten it. We have a student body of about 10,500 students, most of whom, or a significant number of whom, are socioeconomically disadvantaged. It's not a school for rich kids. That's not how it's founded, and that's not how it's continued. Of the 10,500, about 6,000, give or take, are graduate students with a large international component, and a little over 4,000 undergraduate students. This year's entering freshman class of the undergraduate students, about 45% are women, which over the years has changed at MIT. So the men do outnumber the women a bit, but at least, as one freshman told me just the other day, the goods are odd, but the odds are the odds are good, but the goods are odd. So in that context, it's not clear that that advantage really gives you much. But many of the students, especially undergraduates, were the sort of geeks in their class. Many of them didn't have developed social skills. Many of them had never dated. So coming to college is not just learning new things about science, new things about study, new things about humility, but new things about people. Now, in terms of an organizing philosophy of the mental health service, my perspective is that things that we call psychiatric illness and psychological illnesses are natural human reactions to heartache, and that they may not be my way of dealing with things or your way of dealing with things, but that the person is trying to master something that they can't master any other way. That doesn't preclude any neurochemical issues, but it's important to understand the human context in which people present with their symptoms. We've figured out a number of ways to sort of look at the projects that we're up to, and I'll mention a few in specific that mirror a bit about what Earl had started with in terms of sustaining the gains that you make. We're very much engaged in proactive outreach, especially to faculty, administrators, and residential life personnel. So each of our staff are connected to residence halls, but each of our staff are also connected to academic departments. And the idea is to solicit information on an ongoing, through an ongoing regular dialogue with the sources of that information who are aware of and engaged in with students in the student experience. We engage also with student groups as well, but especially with the people that are responsible for teaching and supervising and engaging students. For example, I'm the liaison with the math department. Now, I have no idea what they do there. I have no idea what they study. I've gone to a couple classes to kind of get a feel of it. I didn't understand any of it, and I didn't pretend to because it's so abstract, but people seemed to know what they were doing, and looking at a couple of doctoral dissertations that are nothing like the dissertation I wrote, but it was interesting. But to try and find in some way, and this conversation with the math department came about as a result of a very difficult experience with one of their graduate students. So we spent a fair amount of time with the faculty talking about, the usual things about how to recognize students who are in distress, how to be able to pay attention, how to be able to respond, and then, most importantly, how to be able to engage us. So, for example, I had a call from a math professor with a question. Now, this is how in our context, problems are not raised as symptoms, but as hypothetical questions. So here's the question he said. He said, Alan, I noticed that around the middle of October to the middle of November of the senior year of undergraduate students who come from a former Soviet Union country, that they start to look pale. And, he said, their work seems to suffer. They don't seem to have the same energy and discipline that they did before. Do you think that that's something that you might want to help us with? Now, that sort of awareness is very much what I look for and what I hope for in trying to help faculty to pay attention. We also have active tracking of problem areas that were alerted to by the students in the student newspaper and our student advisors and other offices within the Institute. For example, the Ombuds office, which is part of the President's office at MIT, one of the ombudsmen referred a number of graduate students to me because she had individual and collective complaints of the students, actually they were graduate students, postdocs, and a couple undergrads, about the working conditions in a particular laboratory. I won't mention for obvious reasons which one, in which they felt frightened, anxious, stressed, and entirely misunderstood. Kids weren't sleeping, they were, they just felt awful. And so what we did is the ombudsperson invited me to lunch with them to listen to what they were up against. I knew a bit about it because I had heard the stories of a couple of the members of the lab that were in treatment in our service. So I developed a plan that, with the help of the ombudsperson, I invited the head of the lab, a senior faculty member, to have coffee with me for a consultation. Now, I have coffee a lot in casual ways with faculty members to get acquainted, to learn about what's going on. We also treat in our service faculty, staff, and employees, so I see them around because we have a shared waiting room, which was the recommendation of faculty. They wanted to sit with the students in waiting for their mental health services. So I did a consultation with this professor in which I framed the idea that the professor was doing himself or herself a disservice by the way in which things were working in the lab, because instead of having productivity, they were having simply angst. And the professor took it seriously and then met for a series of, I suppose, counseling sessions, we never called it that, with one of my staff to sort out what was going on in the professor's experience that made things so wretched, and to see if there could be some solution. And that had a pretty decent outcome in the sense that the conditions changed in the lab, but more importantly, the relationship between the professor and the people working there and the students studying there improved when there was some understanding that they were all in it together. So seeing sort of situations that, for example, in programs where there are an unusual number of medical withdrawals, when we identify them, we talk with faculty about how to notice the problems early, because as has been mentioned, that that it's very important to be able to identify problems as early as you can to be able to respond in an effective way. We know that there are certain departments where the environments are more stressful than others. Now, anyone at MIT thinks whatever they're doing, the stress is the worst there. It's a different kind of system. It's a very flat system because people work very much collaboratively. There's not competition vertically, but it's really the idea of people working collectively to solve a problem. So it has a different kind of angle than many situations. But some have elements of stress, especially when we have a department that has a significant number of visiting faculty who aren't quite used to this flat model and tend to kind of work from the top down. And we try and actively engage, in that case, not from the faculty member and student up, but from the dean down. So in this particular case, it involved conversations with the dean and then the department head, then the faculty, and ongoing series of conversations with the teaching assistants and the administrative officers in the academic environment. We try and identify unmet needs and offer very simple solutions. Solutions that are too complex, in my experience, really don't work. For example, Herb had mentioned the problem with doctoral dissertations. We noticed and were told that a number of Ph.D. candidates were having a very difficult time completing their dissertations. Now, that wouldn't be any surprise to any Ph.D. students in here or me, because I remember doing everything other than the work I had to do, so I wouldn't have to attend to it, but sometimes it gets a little out of hand. So we developed a time-limited group for PhD candidates who are having trouble finishing their dissertation. We looked at that in the context of sort of posting this. It filled within half an hour and has been ongoing. We have a procrastination workshop, which meets from time to time when people remember to come, and it is the kind of situation, so there's simple solutions. A very low threshold for engagement by faculty, staff, and others about students they're concerned about. And we try to define our clinical offerings in terms that are part of the university culture, so that we try not to label treatments. We don't talk about dynamic therapy. We don't talk about interpersonal therapy or CBT. But we talk about and use descriptors that are very familiar to people, that rather than asking them to learn our language, we try and do what's involved in their language. Essentially, it's to try and identify areas of greatest concern to the faculty, staff, and to develop plans to address those problems. And I think regardless of one's budget or staffing, there are elements in which the overall approach to noticing problems and making great efforts to engage people dealing with the problems is perhaps one way to manage mental health service in the university. And we can talk some more about it. Thank you.
Good morning, everybody. It's great to follow Bob Winfield and Earl and also Alan. I mean, these folks are really doing some groundbreaking work. And I think I really appreciate, their perspective, because I think, there are some commonalities that Herb Pardes started off with this morning that I want to sort of hone in on a little bit, and hopefully we'll expand during discussion time. Bob kind of kicked it off. He talked about, preventing crisis, and, how do you prevent crisis? Because, at the point of a crisis, we are very much sort of under the gun, and the situation is very, very difficult to control, particularly within the media eye, for example, where I am at New York University. 40,000 students in a highly urban environment, no real identifiable campus. University of Michigan is so lovely, all these wonderful buildings collectively. NYU, anyone who's gone down there can see it's spread out really over a population that's about 3 million during the daytime. Our students are mixing in that type of environment, which creates its own sort of stress and discombobulation. So when we think about prevention, there are two ways I think about prevention. There's primary prevention and there's secondary prevention. Now, primary prevention is what universities excel at. That's keeping people healthy so that disease does not emerge, so that symptoms do not become troublesome. And we think that the co-curricular activities, the academic support, the environment of a campus, that all of these are protective, and no doubt that they are. So obviously, focusing on that in terms of university environments, it's absolutely key. It's primary prevention. But secondary prevention is really what I think health professionals on campus is about. In other words, knowing what we know, that we have large numbers of students arriving on campus who already have received treatments, knowing that campus environments in a global environment creates an enormous amount of stress. We have to do a better job of detecting when symptoms emerge, quickly intervening, and then trying to resolve the problem as quickly as possible. The data clearly shows that when we intervene early, we not only have a better outcome for that particular episode, but also possibly for a lifetime. So I'm a big fan of secondary prevention. Now, how do we do that? A couple of common concepts here. One is this notion of pathway, that Earl talked about. So this notion that all the things we're trying to do, which are put out in a continuum in our community, you've got to figure out a way to channel that. You've got to make it so that students understand that there's a pathway for this. So we have a counseling service, we have a health service, we have counselors in the schools, we have counselors in the dorms, we have all that stuff. But we have to pull it all together. And we have this concept called the wellness exchange. It's a 24/7, 365 days a year hotline, walk-in, and crisis capability. And we developed that. But it's called the wellness exchange for a reason. It's not called the mental health exchange. It's not called the suicide exchange. It's called the wellness exchange. That means they take calls about any health issue, even though we staff that unit with mental health professionals. And that is the key. So we get calls about sexual health, we get calls about all kinds of things, but not just mental health issues. We orient the students so that when they come in, all 4,000 undergraduates, freshmen, understand the concept of the wellness exchange, the numbers that they call, and there's 95% recognition that this is the way, when you can't figure out what office to call, this is the number. It's been so successful that parents and faculty and other stakeholders have jumped in and used that hotline to talk about helping to engage their friends, their student in the class. Parents call it to say, I'm worried, I just got a phone call from my kid, and could you figure out a way to check in on them? And it's just really been this sort of norming campaign around mental health. Health and mental health are inextricably linked. Now, because our time is short and I want to go right into the panel discussion, I want to respect Bob's vision of this panel. Let me try to now talk to you about this dilemma. Now, we can do all of these wonderful things. The problem is that, first of all, students don't know when they're in trouble. It's exactly what Herbert Pardes says. They say, I go to friends first, I go to family first, and all this other stuff. Meanwhile, symptoms are progressing and getting worse. We have to think about screening. We must screen. QPR and other kinds of things are wonderful. I tell you, I'm so excited. I spoke to Todd Sevick last night from the University of Michigan, right here. I said, QPR is wonderful because you're getting good gatekeeper training. But you've got to screen. Now, where's the opportunity? In a time of limited resources, it's got to be in the campus health center. We're getting 50 to 60% of utilization flowing through those health centers, people coming in for routine care, immunizations. Are we screening those folks for depression? We know we should. And so there's an obvious place right there in terms of what's happening in terms of these kinds of dilemmas. So screening is important. I'm sure you're going to have hopefully some questions about that in terms of what the impact of that is. The second is that we fundamentally have a short-term model on college campuses that's anachronistic because what's showing up on our campuses are students with chronic disorders. They're chronic. ADHD, depression, and so on. So in an environment where our models are, I believe, somewhat anachronistic, and then we have the reality that these are chronic disorders, what's the best way to manage this? I'm advocating a shift in philosophy that essentially says that campuses must become the medical and mental health homes for our students, particularly in residential campuses, during the time that students are there. The time when we can say, well, that person's being treated back at home. Back at home is 2 months out of a calendar year. Their home in a residential campus is, in essence, us. And so our resources then must be retooled, reimagined, and quite frankly, added to in order to address this problem. So I can go on and on about this, but I think the most interesting thing is to go right into the panel. I hope I've stimulated some of your thoughts with regards to primary and secondary prevention. So thank you very much.
So I'll be looking for questions, and our vision, or my vision of this was a little bit like Meet the Press, that we would be able to take questions from the audience, but we would also talk about some of the challenges that we've raised amongst ourselves. And I think it would be interesting and fun to talk about the suggestions that Henry has just raised about screening for illness, mental health issues, and the challenges that presents to the counseling services and the resources as you find more and more individuals who need help at a time of constrained resources. So could we hear from either of the other panelists about your thoughts about this?
Okay, I'll start. I mean, the general idea makes a whole lot of sense, and I think it means then there are three questions that jump out at me when Henry was saying that. I mean, part of it, piggyback on what Bob just said, the first stage is screening, and so trying to figure out both the methodology and agreed methodology across the health systems inside of the various universities. Ours place, as some of you know, is also another private institution with about 12,000 students with a large health complex as well. So we have our own hospitals, and which is one of the leading employers in metropolitan Atlanta. But to say that it is both centralized and decentralized would still understate its overall makeup. And so trying to get some agreement both on the methodology. The second part then is once we have those data, how we use them. And going back to the pathways, will we make sure then that we have them, but that we actually are that the students where we see some issues, that we're actually getting to them in a timely fashion that Henry suggested. And I think at our place that may represent the greatest challenge right now. The diagnostic piece would be easier than necessarily getting to all of them given the resources we have, and that's including with our psychiatry department and some of the others. And so then making sure if home is now the residential life on campus, that we don't neglect what that implication is. The third part is cost, and certainly there would be additive costs or incremental costs. I mean, we probably could, and Mark would probably kill me for this, but we probably could think about how to take some part of that mental health fee I mentioned earlier if this becomes some part of the framework and to rededicate. And I say that because this is without me talking to the director of our counseling, who I'm sure already has a dedicated purpose for all that budget. So this is the provost speaking out of turn. But putting those together, it's not to say it's not impossible, but it would require, and I appreciate the actual perspective. It will require some reorientation in ways that we have worked. I mean, for all of the improvement at our place in the last 5 years, silos still exist. And working through the series of silos and building the bridges, and the shock. I mean, exactly, and doing periods of economic contraction, the silos manifest themselves in new forms.
Maybe I could just mention a couple of sort of things that I tried to do that sort of address this, because institutions have varying resources and philosophies about how they spend those resources. At MIT, when I arrived in 2002, about 70% of the visits in the mental health service were for faculty, staff, and employees, and about 30% for students. The students mostly were sent out to the community for care, and that within a year we flipped that so that 70% of the students are inside, of our visits are inside, 30% are outside, and of the students that we see inside, we designate about 20% of the students as vulnerable. We don't really have a technical definition for that, but students who are going to need more attention, with the idea of trying to identify students who we believe, with more intensive and somewhat creative intervention, you can kind of move them back on the developmental track to be able to get back to their studies and get back to participation in student life. Some of it also involves identifying when students really can't do that and working together to try and help the student find some other ways to get some relief. So it's organizing a vision, if you will, and trying to use what you have that really meets the needs of the community, and then working with the political consequences of making changes like that. Because anytime you add something or reduce something, somebody perceives it as suffering, somebody perceives it as a loss, and it is, for the community, a really big change. So the sort of getting used to the idea that things are going to be different is a process.
Let me comment that at the University of Michigan, where I'm the health service director, we have been hesitant to add a PHQ-9 questionnaire of some sort to identify depression amongst the walk-in students or the appointment students, for the reason that we don't know what we would do with these large numbers of students in the setting of constrained resources, and we are hesitant to be aggressive in that screening. We, of course, have a question on our intake form: are you having any mental distress or psychological distress? But we haven't been aggressive, and it's because of those worries about constrained resources. There's already a 7 to 14 day wait once the semester gets rolling for non-emergent mental health counseling. So it's a real challenge. Let me call on Ms. Parker, who has a question.
I have a question and a comment. The question is, Professor Provost Lewis, how is it that I look older and you don't?
I mean, I think that this is why, when the choice came at MIT, whether in order to use resources we eliminate care for faculty, students, faculty, staff, and employees, or continue it in some way, we decided to continue it because the idea was that these people are very much a part of our community. And when we do trainings around how to recognize people in distress and what to do about it, we very much want to reach the centers where the whole community is working, not just perhaps the academic centers. Although if you train the people that clean the residence halls to pay attention and you give them a way to tell you about what they're noticing, you kind of learn a lot. Sometimes you learn more than you want to, but you learn a lot because they see and are part of what it is that student life is really all about.
Let me, did either of you want to further respond? For instance, Earl, about how handsome you look?
All I can say is I think I'm aging from the inside out, and so...
Dr. Graydon.
First, thank you to the panel members. Second, knowing that competition and modeling and just examples set by others are really important as we try to implement changes, not just talk. Earl, I'm wondering whether you might have any suggestions for the rest of us as to how we could get other universities to emulate even some of the pattern of saying, let's figure out a new strategy for generating money to pay for these things. Inevitably, it is the shortcoming. And I would love it if we could figure out a way to say this is being done at some universities, it's showing the following positive gains. Students like it, and I suspect we would see others follow suit. Help us out.
I actually go back to the comment I made about student leadership. Here's a case where, and I'll take it back to our student government, but where they talk to their peers across the country and explain that in a world where most universities, public and private research universities, are going to realize that the elasticity for increasing tuition probably peaked this year. And my guess is nationwide that we will see a decrease both in the absolute dollar and a % increase for the foreseeable future. But there are some real costs, and so if you pull those out and show the students what the tangible benefit is, and this is what our student leaders said, they'd be willing to not only pay those additional dollars, but embrace it and support it. And so if I were to suggest anything there, it's actually where student leaders talk to one another with support from the senior administration. But if students are campaigning for something that is targeted, my guess is it will happen, and particularly if you can show that it's been being dedicated for the purposes that they're designed to be dedicated for. Yeah, actually, this is a case of where leadership is not just people like me and presidents of universities, but it's actually the students have some responsibility for making sure that they are getting the services they need and willing to sort of target certain parts of their resources and that they are contributing for those purposes.
Not to this question, no.
Okay. Before I call on you, I want to stimulate a little discussion here on three questions that came together on resources. Two of the universities here have had mental health task force, MIT and Emory. One was triggered by a tragedy. Emory was triggered proactively by Earl's thoughts. I don't know whether NYU has had a mental health task force. You also had a series of suicides that triggered a mental health task force, and we also had a suicide that triggered a mental health task force. So the questions that are here are, have you met resistance from higher administration regarding ideas addressing student mental health, and how have you handled this resistance? How have you coordinated and mapped out the resources necessary? And I think, Earl, you've already mentioned about the $50 student fee and how you dealt with that. So could we address the idea of how to work with the resistance that one might face in higher administration, especially in constraint of dollars or stigma, and how do you coordinate and map these out?
So I think the issue of resources obviously is critical to building the kinds of capacity I was commenting on in my talks. I think first and foremost, you have to provide data to your stakeholders. And I know that a lot of us sort of have looked at the NCHA data and our own campus NCH data as one of the ways that we sort of make the point. But the way that we've gone about it is that we have really sort of taken the notion of measurement and screening and other kinds of things to really kind of make the argument that these folks are already coming in through our doors. In other words, there's no way of keeping them back. They're utilizing our health services, they're utilizing our counseling services, and here is how distressed they are when they come in, whether they know it or present for a mental health problem or not. So many of our schools who are involved in our collaborative are beginning to measure this. And when you show people that students who have tremendous mental health needs are actually coming in through the health service with very high depression scores, yet they're not presumably presenting for depression treatment, that's a lost opportunity. And that data has been extremely compelling for some of our under-resourced schools in the project. So, for example, what they've done is they've taken that data to trustees. And trustees have responded and said, oh my God. So what you're telling me is that if I keep putting resources into counseling, this whole segment of this population may not ever actually get there. And the notion that students, so many of them who receive treatment at home, are getting treatment from non-mental health providers. They're coming on campus with those medications prescribed by nurse practitioners and primary care physicians and others. How do we respond to that? So I guess my argument has been, let's get some good data together. Let's make that data compelling. Find in your local campus the people who are willing to contribute, who can build fees the way Earl is talking about, who've got deep pockets, and say, this is a tragedy, and you've got to respond to it.
One thing that might be useful, at least in my work at MIT and other schools that I have worked with, I think you can try and frame an argument for how the mental health service can enhance the academic mission and purpose and link the two together so that we believe that we can provide skills for the students so they can better engage in their studies and participate in campus life, and that we can also identify students who can't function academically and figure out ways to be helpful, so that rather than it be the mental health service remains kind of a service unto itself, that our function really is to enhance the larger mission. I mean, universities are not there to provide mental health services. They're there to provide educational experiences for students, and the mental health service needs to understand that in and of itself, that's its mission too, supporting that function. Often that argument with data can be useful in helping administrative folks see the linkage between the service and the major mission of the university.
And the last thing I want to add is that remember that I and others in my guild can be educated. And so part of it is to actually sit down as part of an overall sort of lesson plan on the key things that you want to get across. And like any lesson plan, sometimes you have to repeat that lesson once or twice or even 3 times. But we can learn. And what I have seen over time is that, in fact, not only can we learn, but we're receptive to learning. We will ask for the data. We'll ask other kinds of questions. And there are different ways to frame it. I mean, for a number of institutions, for a variety of reasons, including federal policy, there are enterprise risk management sort of operations. And so you sort of can, for some, you can frame some part of it there. For others, as U.S. News and World Reports, and you're looking at your attrition rate and you're trying to figure out why your attrition rate is as high as it is, and can you intervene in such a way as to help students actually to be more successful in their first and second years in school. And so it's utilitarian in the sense that you're providing services to reduce the attrition so as to make sure that you are as attractive in the future as you have been. But there are ways in which you can frame a lesson plan, educate the leadership, and there's, I think, no substitute for continuing to educate.
Sure.
I had a quick comment and then a brief question. The comment is that I agree with you, Dr. Chung. I know no other health issue in this country where our solution is let's just not find out what the extent of that issue is. So you need to stay on target with what you're talking about, and it's part of what I do, some of the work that I do. So the question is, since each of you is from a major metropolitan area, and at least one of you, Dr. Lewis, alluded to some involvement with your community mental health service. Could you expound on that a little bit more? Where we talk a lot about the campus service, but what's its interaction and the need for its interaction with its community mental health operations?
Go ahead, Henry. Oh.
So I think, is that Victor? Yes. So, Victor, your question is so key because it goes to the heart of the issue that these are chronic disorders. And right now, most health services and mental health services are not resourced to fully provide what we believe are these chronic level services. And as Alan mentioned, there's a certain population that we consider vulnerable, and so special attention has to be addressed. One of the things that we have tried to do is to work with community mental health partners, both at the private level and the system level, to have a safety net approach whereby students that we're concerned about sign an agreement and a release before they are referred out. And they basically give us permission to proactively reach out to the therapist to find out and do some check-ins with the student and the therapist when they've been referred out. And then also it allows the therapist in the institution to inform us when the student drops out of treatment. This is the Virginia Tech solution. I mean, this came into play right after VTech, and I looked at the situation. I said, how many of these students are we referring out who have chronic psychotic disorders and where there was a threat of either violence to others or violence to themselves? And it turned out that roughly, at that time anyway, 50% of our referrals were meeting this type of criteria because we were rapidly trying to get them into the community because they were chronic. Now, that has changed somewhat because we're taking a more proactive approach that says we're going to take a lot of responsibility for these folks because we have to stay engaged with them. We can't allow them to drop off our radar screen. And so it's been fairly effective so far. Is it foolproof? No. It depends somewhat on people remembering those agreements. But we have staff dedicated now to just this purpose. They have a list of all these people who have signed these agreements, and it's part of their responsibility every month to 2 months to check in with that external provider and say, is this student still coming? And we have saved lives that way, I can tell you, Victor, for a fact.
I think there's a variety of things to follow up on Henry's saying that you can do. It's obviously, community specific, but you sort of understand that you're all in it together. So that, for example, we have students tutoring in the high school, and we're in touch with high school guidance counselors to see if there's some way we can be useful to them, either in preparing students for college or getting our admissions people involved, or other kinds of needs that are within the high school that perhaps are unmet. We had an industrial accident at a building where some work was being done adjacent to a community housing project a couple of years ago that was visibly very, very disturbing. And so I contacted the head of the housing authority and said, I realize that members of the residential area may have witnessed this. We'd like to come in and do some debriefing and to make ourselves available to our neighbors to talk about what they've witnessed and the trauma of that, and to help them get referred into appropriate. So it's kind of thinking beyond your boundaries to understand the impact that you as an institution may have in the community and what to do. We have a considerable homeless population in Cambridge, and since I knew all of them when I was at Cambridge Hospital, when I went through Harvard Square, they followed me to MIT, much to the discouragement of the MIT campus police. But, I know them, and we know then how to maybe what they need and how the university can be helpful to the disadvantaged people that we live among. So there's a lot of different kind of possibilities, I think.
I'll just add one that's actually not an external referable, an internal one. I mean, part of life on the Emory campus is that many of our students first present themselves not in counseling or in health services, but actually in our religious life programs. And so our religious life actually plays a major role as part of the overall matrix of services. And so they have, and it's been referred in both directions in a way, and there's now a coordination team between the essentially the Associate Dean of Religious Life and the Director of the Counseling Center to make sure that we, one, are missing students, two, and that if there's a way to intervene earlier on and one avenue is more effective than the other, that we refer them there to at least begin the initial set of conversations and treatment.
And that's interesting. That reflects some comments made by Ralph Williams last night about how difficult it is to help a student navigate between financial aid and academic advising, perhaps the Association of Religious Counselors, CAPS, Health Service, and as many of us do with Eating Issues networks, where we have the clinicians meeting with the counselors, there may be some solution out there in the future where we can find a way of networking better. Ma'am in the red.
Is this actually working? Okay. Gentlemen, I am fortunate enough to know a little bit about what goes on at each of your campuses, and also have worked with 60 or so campuses who are suicide prevention grantees over the last 3.5 years or so. And one campus I'm working with rather intensively right now is a very small rural campus with no resources on campus and and sort of, working their way through creating some of the infrastructure that they need to in order to then go out and find the students who are at risk and try to bring them to services. The question I have almost every year at this conference, and some of you have sort of gone there, in particular Alan Siegel, and by the way, full disclosure, I dated MIT men as an undergrad at Simmons. So I fully know what you're dealing with. The resource allocation question always seems to focus on the resource as being more therapists. And in fact, a public health approach would suggest that preventing students from getting to the point of needing therapy in the first place might be a good approach. And if you look at Arizona State does a really nice job graphing the ACHA data from the large number of students who have minor stress based on certain questions, and then the smaller subset of students who are very, very distressed, and how we sort of intervene at the point. We also know from the Healthy Minds data, for example, that current financial difficulties are being poor growing up. We know the relationship between academic problems and either mental health or suicidal behavior. And I think this is in part a comment, but something for you to react to as a question as well. It suggests different resources, like developing relationship skills, because relationship difficulties are huge with students in terms of risk factors for those things. Financial counseling, not to give students more money to solve their financial problems, but to help them work them through. One of our grantees even banned credit card companies from marketing credit cards on their campus and established an Office of Student Financial I forget the exact term. Some of you talked about groups that aren't called groups, et cetera, but there are a lot of good ideas for using resources more effectively that don't involve counseling centers as being sort of the center of the universe. So it's sort of beyond being partners with everyone, but how do you take on promoting the mental health of all students? And then I'll say one final thing, and another full disclosure is I'm a master's level clinician. I notice a very large bias towards hiring Ph.D. clinicians on college campuses, and they're frankly more costly. And I think that is also an issue that could be looked at. And I've never dared say that in the 3 years I've been to this conference.
So is that Laurie? Is that Laurie Davidson? Is that Laurie? I think it's Laurie. So Laurie, I think you've raised some really good issues, and in fact, we have begun to repurpose some of our staff for just those primary prevention activities. We have a student insurance office we have a product, student insurance plan. They are now trained to do financial counseling. And so when students have plans other than the student insurance plan, and they have problems with bills, paying their explanation, looking at the explanation of benefits, trying to figure out whether or not it was paid correctly, what their out-of-pocket is, we have all of our student insurance staff trained to manage those kinds of questions, to rave reviews from parents and students, because as you know, we get so confused when we look at these explanation of benefit statements. So it's really a tremendous thing. The other thing is that we are now in a dilemma, all of us, in the fact that we're devoting more and more resources to students that are higher risk and have chronic disorders, to the detriment, really, of these students who have more what we call minor complaints, but really a lot can be done with them. And so we have begun to push them into life skills groups as quickly as possible. And the life skills groups are things like public speaking, battling insomnia, all of these kinds of things, which are really pseudo group therapy type elements with a curriculum. But the idea is that they can have some normalization with some peer approaches. And, that has been very effective. We've grown our group therapy program that way. And third, to your issue about manpower, I think you're absolutely right. Our staffing now is much more even with regards to master's level clinicians, particularly in the social work arena, versus a Ph.D. and M.D. type folks. Because why? Case management is absolutely huge, and we are not addressing the case management gap in our models for the most part that I've seen.
I mean, I think to follow up a little bit, I think it really is whether you conceive of yourself as a service provider or a consultation resource. If you think of yourself as a consultation resource and you then try and see how you can be helpful to different areas of a college or community, you can make some gains. When I was at Cambridge, I was the consultant to the public library system because they had lots of people studying in the library, so to speak, that they were worried about. And the notion of being able to be helpful in making the library a different place for the patrons that worked there was something we paid attention to. It's the same thing in a university setting, that if you think of it only as what am I going to do in the office, or what am I going to do in dealing with the students that come to everyone's attention, you miss 3/4 of the needs of the campus. So it's trying to demonstrate a balance that could be helpful.
I'm so sorry, but we're out of time. This is such an... Is Trish there?
Yeah, right down here.
What do I do, Trish?
Great.
All right.
Okay.
Please go ahead.
Oh, wonderful. Thank you. Dave Katznick from Wisconsin. There's sympathetic to the issue in terms of the concern about screening more people and students without knowing what you're going to do with them. Some of the work that I do is with depression in primary care settings, and outside of colleges, 70–80% of people with depression and anxiety get treated in primary care, and there's more and more models with like MacArthur and Robert Wood Johnson with identifying people with severity and doing triage and doing step care. And I wonder if the group could say more about increasing the capacity within primary care on campuses to be doing self-management, initial medication for people with less severe mental illness to increase capacity, rather than just sort of it being a all or nothing. If you got identified, you go to counseling.
So David, you know this methodology very well. I mean, the idea is that we don't impose a blanket solution in the beginning. And it's very important that you not overwhelm the system. To Bob's earlier point about if we screen, we must then deal with what happens. That assumes then that whatever you're screening positive, you're automatically referring to counseling. We know that that's a disaster. In fact, when we've tracked studies, and I have a paper in submission right now on college health, that shows that if you simply screen and then refer to counseling, and that's the only option, you basically get a 50 to 60% drop-off because they won't go. So simply identifying and screening is not the answer, and Bob's absolutely right. You've got to figure out a way then to do it. And the methodology is that among our campuses, whether they're rural or urban, there's at least 1 or 2 providers on the health service side who have that kind of attitude that says, well, I used to do this, and I stopped doing it when I was in college. And the reason because we have this wonderful counseling service and psychiatrists, so I just simply refer to them. And if they begin to take on then these, small number of cases perhaps that already are on their panel, so they begin to screen their own panel, so to speak, and they basically learn the stepped approach, which is using a PHQ-9 or using a Beck depression inventory. What is so severe automatically needs counseling, but something in between where a student says, well, I would prefer to stay with you, doctor or nurse practitioner. Can you help me? That we provide them those skills, which includes, early medication management if the student prefers, or if not, a self-management approach, which the provider then can assist the student in terms of doing some self-activities and self-activation activities that we know also help for more minor stages of depression. So, but you know this very well, David.
I'm going to ask a question further here. Do any of you know whether or not there is research evidence showing that providing mental health treatment within college campuses has either improved retention or improved performance and academic functioning?
So, the work that a lot of us cheat on here is that we go back to Richard Caddison's work and analysis, and he took, I think in 1 year's time, some what we would consider open label data, which means there was no randomization, but he said, well, you take this number of students who went through counseling, and these number of students then were retained versus a couple of other students who dropped out of treatment and did not go to counseling. And you could show that among those who stayed in counseling versus those that dropped out of counseling, and those who stayed in counseling were stayed in school. So a lot of us have been kind of cheating using that small data set to say, well, see here, this is why you should support your counseling center. The problem is that, you still have a large number of people who don't engage in counseling. So does that mean that we give up on them? And so I think, Bob, to your point, you're absolutely right. There isn't, to my knowledge, a robust study that supports that. Now, I will say that we're trying to get at this directionally through our project, the National College Depression Partnership, where we are not exactly looking at retention, because I'm worried that if we go down that road, it's a blind path, because some would argue that some students may not be ready, and in fact, retention may not be the best way of looking at whether or not we're providing value to the system. So instead, we're looking at issues of engagement and learning, and we have a couple of metrics that we've put into our new project, looking at overall function, including social, academic, and overall global functioning. And then we're also looking at engagement in terms of how well engaged then, as a result of treatment, students are in their academic and co-curricular activities. So we're not quite ready yet to present that data, but we should have it by the end of July.
Thank you. Now, if there's others that have questions, please feel free to come up to the podium. There is a short break, and then we'll have breakout sessions starting at 10:45. Thank you very much to the panelists.